What's up, AP Psych? This is your lecture on psychoactive drugs. The things that we need to learn about psychoactive drugs are how they affect behavior and mental processes. We need to know more about them in terms of categories than specifics, though I will talk about a few specific drugs just to kind of drive home my point. And we need to know about agonists and antagonists, which we will also talk about extensively in class, um, and tolerance and addiction. So let's get to it. Psychoactive drugs, these are drugs that specifically alter perception and mood. So there are lots of drugs out there that do other things for us, things that like thin our blood, take care of our allergies for us. Stop it when we have an upset stomach. That's not what I'm talking about here. Psychoactive drugs are specifically a category that changes how we interact with and perceive reality. So, like if we're happy, we might get really happy. If we're sad, we might get really sad, actually. Um, or we might have a drug that helps minimize feelings of sadness or hopelessness when those are naturally occurring and they're naturally occurring in a way that's overwhelming. So anything that affects our consciousness, some of these are prescribed by doctors and for very legitimate purposes, but unfortunately, a lot of what we're going to talk about today are the sorts of drugs that are abused because they're used recreationally for fun, and that's actually quite dangerous. The other really important thing before I move on is that these drugs interact with our neurotransmitters at our receptor sites on our dendrites. Pew, pew, pew. Well, it's the part receiving the pew, pew, pew. um, and so it's definitely altering your brain chemistry, which is why it affects your perception. And perception's a big enough topic that it will actually get its own lecture in Unit 2. But yes, I'm referring to the way you view or interpret the world. Before we get into the drugs specifically, let's talk about agonists and antagonists. I'm somewhat going to just read through this slide because we are going to go through this extensively in class. All drugs are either agonists or antagonists or reuptake inhibitors. I'll get to that in a second. If a drug is an agonist, it is mimicking or copying a neurotransmitter and fits into a given receptor site on a dendrite, just like it was that neurotransmitter. It will increase that neurotransmitter's effects. So, like morphine is a very potent pain reliever that doctors will give you perhaps if you've had surgery. It mimics endorphins, our body's natural painkillers. So, when given to us by a doctor, that morphine injected into our body will fit into the same receptors as endorphins, tricking the body into thinking it has extra endorphins to help take away very severe pain. So, agonists, copying a neurotransmitter to increase the neurotransmitter's effect. Antagonists block neurotransmitters from being released or received, and they prevent the neurotransmitter's effect. So acetylcholine gets released, pew, 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 and sent over to our nerves when muscles need to contract. Botox is an antagonist for acetylcholine, and so it prevents acetylcholine from being received, preventing muscles from contracting, and then it actually relaxes the face and gets rid of wrinkles for a few months at a time. So the Botox is an antagonist blocking the acetylcholine from being received, preventing the muscles from contracting. And then finally, reuptake inhibitors block the reuptake, kind of like the name implies, of neurotransmitters back into the cell, into the nerve cell, the neuron. If you don't like the word cell, I'm just realizing it's a neuron, so feel free to add that to your notes. So more of that neurotransmitter is sitting there ready and waiting in the synapse for the next firing. So some people have heard of SSRIs. These are selective serotonin reuptake inhibitors. So when someone takes something like Prozac, if they have been diagnosed with clinical depression and the doctor has prescribed it, that Prozac will block reuptake of serotonin. So serotonin will be fired, pew, 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 will go across to the dendrites looking for its receptor sites. And if it doesn't find one, instead of typical reuptake where it would go back into the neuron that fired it, it would kind of just hang out in the synapse either hoping to make a connection into the receptor site still, or waiting for the next firing so more gets pushed across to the next neuron, so that person who is struggling with clinical depression feels an extra boost of serotonin, which we know is a neurotransmitter that helps with mood stability. So again, I'll go through this much more in class. This is very technical. Over time, as someone takes the same drug over and over again, the body might develop substance dependence, or what we commonly know as addiction. This means that the body has adapted to the drug so much that it's developed a tolerance, and then the body needs that drug more and more to feel functional. So if we think about it in terms of something easy to talk about, which is melatonin, um, it's like saying if you take melatonin every night to help you sleep, with repeated use, that melatonin is not going to help you sleep anymore. The drug's effect lessens. So someone would need more and more of that melatonin to get the desired effect. Because what your body is doing is it is adding on more receptor sites to compensate for all this extra, what it thinks is neurotransmitters, even though it's the drug, all of this extra boost. And then all those sites get filled up. And now the body no longer knows what's the natural amount of serotonin, not serotonin, I'm sorry, melatonin or GABA to create for its own sleep purposes. This is considered substance dependence. It's considered a biological and behavior disorder. Biological because the body literally starts to need it to feel normal, whatever the drug is, and behavioral because a person will often desire it or might have their moods change dramatically if they don't get it, they don't get the drug. And then if they continue to not get the drug, they might experience withdrawal symptoms. Withdrawal are symptoms that occur when a drug-dependent person stops using that drug. The body is no longer producing the natural neurotransmitters. So the natural acetylcholine, the natural endorphins, the natural dopamine, the natural GABA, whatever it is, because it's being replaced by the drug kind of artificially in the form of agonists or antagonists. And so a person might go through physical pain, intense cravings, that's considered a physical need, or negative emotions as they kind of come down off of that drug. So you can see here are some examples. You don't need to memorize these, but here are some examples of both physical symptoms and psychological symptoms that someone might experience with withdrawal. Okay, as I said, it's less important that we know drug by drug by drug what happens to our bodies, because we are going to study them in terms of categories with a few examples and exceptions to what I'm saying, meaning we'll go in depth in a few of these, and we might go into a little bit more depth in class. But we have three categories: depressants, stimulants, and hallucinogens. And within depressants, we're going to have a subcategory of opioids, which are kind of becoming a category of their own. Okay, first category, depressants. These are not depressants in that they make you sad or depressed. These are depressants as in they slow down your body functions. They reduce activity, slow body functions. So these might slow your heart rate. They might slow down your ability to make decisions quickly and react quickly. They might disrupt your memory altogether. Common examples are alcohol, opiates, and barbiturates and benzodiazepines. Barbiturates and benzodiazepines, you could put the word down tranquilizers or tranks. These are sometimes properly used as anti-anxiety medications, perhaps antidepressants, but when they are abused, they are basically kind of numbing you to the world. And you can see, we'll look at this graph more in class as well, but you can see barbiturates, alcohol, and benzodiazepine are all pretty high on this graph I have, comparing the risk of physical harm to the risk of dependence, meaning they are both dangerous to your body and they are highly addictive. Alcohol and then heroin as a form of an opiate are two good examples of depressants. I would suggest you listen to what I'm saying and then add to your effects part of your notes of depressants. Both of these drugs will decrease pain, anxiety, maybe contribute to relaxation, which is often why people go to these drugs, but it might do it too much so. It might create disinhibition. If you think of the word inhibition, your inhibitions are often good. They make you more careful on what to say or do when you're sober. But if you are on one of these drugs and you don't have that sense of being careful, you might say things you don't wish you would have said later. You might make decisions that you wouldn't otherwise make. In fact, your decision-making process might be a little bit slower, but more impulsive. You might experience depression, memory loss, impaired reactions. Your reaction time will probably slow. For alcohol, the same amount affects women more than men. That's important to recognize. And then we will talk more about opiates and heroin in class, but because of the way it slows down pain and anxiety, it will leave someone feeling a sense of euphoria, and it is highly addictive very quickly. Within 1 or 2 doses or experiences with this drug, someone could become addicted, where some of the other ones, it might take more experiences with the drug to become addicted. Our next category is stimulants. These sound like what they say. They sound like the opposite of depressants because they are. These excite neural activity and speed up body functions. Common examples are caffeine, cocaine, nicotine, methamphetamines, and MDMA, which is more commonly known as ecstasy. So, two common examples include caffeine and cocaine. Some examples of the effects of stimulants: they might increase alertness, heart rate, breathing rates, make you feel like you have a ton of energy, make you possibly feel like you have a lot of confidence. The problem with this, the downside, because that might sound, at least part of that might sound good, is that it will stress out your heart. It might make you feel paranoid. It might give you insomnia or increase a sense of anxiety because your body is so hyped up and responding in kind of like a fight or flight, increased sympathetic nervous system kind of way. And it's a false sensation. And then when they wear off, the crash that a person will feel just internally, a mood crash, an energy crash, all of that sort of thing is very severe, leaving a person feeling like they need to reach for their stimulant again to feel back to normal. Our final category are hallucinogens. Hallucinogens distort perceptions or manifest or create sensory images that aren't really there. When I say sensory images, anytime I say sensory, quite frankly, I am referring to your sense of sight, hearing, taste, touch, smell. Those are 5 senses. There's actually a few more, but we'll stick with those 5 for now. I'll teach you the other ones later. And if a person is on a hallucinogen, they might feel like they're seeing colors and images or figures that aren't really there. They might feel something on their skin that's not really there, feel like they smell something, taste something, and so on that aren't really there. These are sometimes called psychedelics because that word means mind manifesting. Your mind is creating these images, sensations that aren't really there. Common examples of hallucinogens include marijuana, LSD, psilocybin, and peyote. And you'll notice that marijuana has an asterisk next to it, which brings me to the fact that it kind of is its own category. Or more to the point, it can fall under all 3 depending on the type of marijuana and a person's individual experiences with it. The main chemical that makes a person feel the drug-like high is THC, not CBD. THC produces the high and can remain in the body long after use. Up to 10% of THC might be able to be detected even up to 7 weeks after marijuana has been ingested. It can act like a stimulant and a hallucinogen in that it will enhance sensations. It might relieve pain, therefore making someone feel like they have more energy. However, it might also give a sense of relaxation or depress anxiety, which makes marijuana fall somewhat into the depressant category. Regardless of the category, marijuana can also impair coordination, concentration, and memory, and anything that is smoked could create lung damage and likely will create lung damage. Smoke is not meant to go into your lungs. With chronic use, it can develop a permanent decrease of motivation in all things in life, and it can produce lasting impact on reproduction, specifically in males. Finally, drug use is heavily both determined by and an influence on experience by biopsychosocial factors. What I mean by that is a person deciding to use drugs will likely have influences from biology. Perhaps there's something in your genetics or in your dopamine reward circuit that makes you more vulnerable to drug use, or more motivated to drug use. A person might be experiencing a lack of purpose, stress, or other mental health disorders that psychologically makes them want to use drugs. And then, of course, you're no stranger to the fact that peer pressure and cultural norms are sociocultural reasons why someone might use drugs or alcohol. And so if it's very normal in your social circle, it might feel like a very normal thing for you to do as well. But then your experience on a drug also has a biopsychosocial component that boils down to your expectations of a drug. If someone tells you it's going to be amazing, you're probably going to feel like it's going to be amazing, or you might feel it to be amazing. If you feel like it's going to make you more upset, it probably will make you more upset. On that note, drugs and alcohol tend to take whatever you're already feeling or dealing with and mask it, or what we call acerbate it, which means like amplify it. And then depending on the conditions in which you take it, if you don't necessarily feel an increase in sadness or anger or something on the drug, very often when you come down from the drug, you're left feeling worse than you did before you took it. Okay, we will talk about this one more in class. I will answer some questions. I will go into a little bit more depth on certain drugs, but that is it for your psychoactive drug lecture.